A second, madam, I'll discuss it. Go live, Madi.
Again, sir, go live. Live
Here,
actually.
madam. Go ahead, madam. Go ahead, madam.
Okay, sir. Okay, thank you. I think now I'm audible. Dear participants, have you come? Anyone? Anyone? You can say yes.
Yes, madam, we can listen.
Okay, okay. Thank you. Thank you very much. Today's topic is spleen. Okay. By spleen, by and large, spleen means you will be reading more in medicine. Okay, it's a very important organ. What are the different causes of hepatomegaly, splenomegaly, hepatosplenomegaly? Most of the time, you will be reading about the spleen in cases of many hematological disorders, infectious disorders. What are the indications? What are the contraindications? How to palpate the spleen? Everything. So you will be learning more about spleen in the medicine department. But what about its surgical relevance? How relevant is spleen in surgical aspect? There are certain conditions in which we as surgeons, the patient will be sent to us to evaluate, and sometimes if splenectomy is necessitated, then we have to go ahead with the splenectomy. For this reason, we should know what are the different conditions which can cause splenomegaly and what are the conditions in which the spleen can be preserved or it can be removed. If removed, what are the complications? And then what are the different post-operative, pre-operative procedures and the post-operative care to be taken for the patient. So we'll be going in a detailed manner. What are the different indications of splenectomy? What is the pre-operative preparation, post-operative complications, barring portal hypertension. So today I'm not going to deal about the portal hypertension. Okay. First, everything for surgery, everything A for anatomy. It's A for anatomy for us. So coming to the brief anatomy, as you all know, it is a wedge-shaped organ. Okay. It is situated in the left hypochondrium, as you all know. Okay. It is well protected under the rib cage and it is present along the long axis of the 10th rib. Okay. Previously, in olden days, what they used to think was, it is called a plenum mystere organum. Okay. It means the organ full of mystery. What does it mean? That means by and large, its function was not at all known. What is its function? Why it is there? Many people did not know about the function of the spleen. But until recently, it is many of the splenic functions have come into picture. Okay. So in English, okay, in English language, the spleen means bad temper. Okay. So it means bad temper. Most of its functions are not known, and majority of the times its function was not known, why it is getting enlarged and what are the problems, why are the problems, all this happening because of the splenomegaly. By and large, till recently, its function was not known. Okay. But first splenectomy was documented in 1893. For some reason, the splenectomy, first it was conducted in 1893. Okay. Then coming to the anatomical aspects and the functional aspects, it is largest organ of rhymphoreticular system and also the most vulnerable organ of traumatic injury to the abdomen. So isolated splenic injuries are rare. Usually it is associated with the left-sided rib fractures or left hemothorax or pneumothorax, and usually there are multiple coexisting injuries if at all spleen is damaged. Isolated splenic injuries are very rare, and this is the most common organ to get traumatized in cases of road traffic accidents or any other injuries. Usually in the blunt injury abdomen, the most vulnerable organ is spleen. Okay. You can remember this mnemonic. Okay. You can stop me at any time if I am proceeding in a fast manner. Okay. You can remember this. One thing, 1 inch thick, 3 inch wide, 5 inch long, 7 ounce, that is 200 grams in weight, and it is present along 9 to 11 ribs. So you see, look at these odd numbers: 1 inch thick, 3 inch wide, 5 inch long, 7 ounce in weight, and present along the 9 to 11 ribs and long axis along the 10th rib. So this was one of the MCQs asked in the previous papers. Okay. Coming to the ligament attachments and different anatomical aspects of the spleen. See, if you see this picture, this gives you a gross idea. It is most commonly associated with the lowermost ribs on the left side. It is a wedge-shaped organ present in the left hypochondriac region, and it is well protected under the rib cage, and it is closely related to the diaphragm, and there are many ligamentous attachments which I will be coming shortly. This is the splenic hilum, and it is closely related to tail of the pancreas, adrenals, as well as left kidney, and on top of it there is stomach. Okay, so there are multiple ligamentous attachments which prevent displacement of the spleen. Since it is present right below the diaphragm, it is more prone for any movement, abnormal movements. So that is prevented by the various ligaments. Okay, so the important ligaments are, one is gastrosplenic ligament. So as the name suggests, gastrosplenic, so there is a ligament connecting spleen and the stomach. What does it carry? Please remember this. Okay, it carries short gastric vessels. Okay, there is another important ligament called lino-renal ligament, which connects the spleen and the left kidney. So this carries very important splenic vessels, and it is very closely related to the tail of the pancreas. Okay, there is another ligament called splenocolic ligament. As the name suggests, this ligament connects colon and the spleen. Okay, there is another ligament called as phrenicocolic ligament. Okay, so phrenic, so it means it connects the diaphragm and the colon, and it also supports the spleen. Okay, and very importantly, near the lower pole of the spleen, it has to be very carefully dealt during splenectomy, because it might cause injury to these ligaments, and invariably it will cause torrential bleeding. Okay, there are many vital structures. So if you see the lateral view, okay, so this is the spleen and this is the hilum of the spleen. Look, it is very closely related to the tail of the pancreas. It is almost near the hilum, and this is the superior border of the pancreas. So it is where the pedicle is ligated during splenectomy. Please remember this point. This was also asked as an MCQ. Along the superior border of the pancreas. So he has given multiple options, like at the hilum, okay, at the inferior, at the near the kidney, near the tail of the pancreas. No, it is not the option. Usually we ligate along the superior border of the pancreas. So this is the spot where you are going to ligate the splenic pedicle during splenectomy. Okay, as you all see, you can see multiple ligaments and their attachments. Okay, so it is the ligament connecting the colon and the spleen. Okay, there is also a phrenicocolic ligament, gastrocolic ligament, and multiple ligamentous attachments. Okay, which prevent the displacement of spleen. Okay, coming to the one of the MCQs which was asked, downward displacement. See, please remember, downward displacement of spleen is prevented by, any guess? Any guess, doctors?
Phrenicocolic.
Yes, phrenicocolic ligament. So this ligament helps in the prevention of downward displacement. So it keeps the spleen most of the time, almost 60% of the support is from this phrenicocolic ligament. Okay. Next, coming to the blood supply. It is very, very important to know the entire anatomy of the GIT, blood supply to the GIT. As you all know, the majority of the blood supply is from the celiac trunk. Okay, the celiac artery, it gives mainly 2 left branches and 1 right branch. The 1 right branch is right, that is common hepatic artery, and the 2 left branches are left gastric artery, and the largest branch of celiac trunk is splenic artery. So the most of the blood supply comes from the splenic artery. It is the longest artery of the celiac plexus, and it has certain curvilinear course. It has a long course, okay, and it is a branch of celiac artery. And splenic vein, okay, the splenic vein joins the superior mesenteric vein behind the neck of the pancreas. Please remember these landmarks. Behind the neck of the pancreas SV and SMV join to form the portal vein. Okay, the splenic vein and superior mesenteric vein behind the neck of the pancreas form the portal vein. Okay, and there is capsule of the spleen. Okay, and this is also very, very vascular. There is an important structures called capsule and the parenchyma of the spleen. What does the parenchyma contain? Parenchyma contains there's something called as red pulp and white pulp, which you have studied in your histology and your pathology. What does the red pulp contain? Okay, as you all know, the red, okay, it is mainly the vascular structures like cords and sinuses. As you all know, spleen is a very, very richly vascular organ. So any trauma will cause torrential bleeding or hematoma formation and shock. So it is highly richly vascular organ. So the red pulp consists of cords and sinuses, lot of blood. It acts as a reservoir of the blood, and there is central artery. It ends in the cords and sinuses, and there is something called as marginal zone. Okay, and the white pulp. So as it is a part of lymphoreticular system, so it should contain both the blood supply and also the lymphatic centers surrounded by the trabecular arteries. So in case of any reserve, so it acts as a reserve for so many things. Okay, it can act as a reservoir of the blood and also the platelet reserve. Whenever there is sudden fall in the platelets or blood, immediately spleen responds and pushes these cells into the circulation. Okay, so it is very, very important reservoir of certain blood cells as well as even blood also. Almost it contains 20 to 30% of the blood as reserve. So whenever there is shock, immediately the spleen responds and sends these cells into the circulation. So this is the white pulp, okay, which contain predominantly the WBCs, okay, and this is the red pulp consisting of cords and sinuses. So there is marginal zone, okay, there is marginal zone and there is red pulp and the white pulp. What are its functions? So till recently, majority of the functions were unknown, but now the splenic function has been extensively studied and certain functions have been identified. One is spleen. It's a very strict organ, okay? It does not tolerate any deformed cells, especially RBCs, okay? So any deformed cells, either in the shape or in the volume, or if their cell wall is it's weak, if the cell membrane is very weak, immediately such abnormal cells will be destroyed or sequestered in the spleen, okay? Especially RBCs, okay? So these deformed RBCs will typically form the Howell-Jolly bodies, okay? Okay. Suppose if the patient has undergone splenectomy, okay? So if there is Howell-Jolly bodies, it means that the splenic function is gone, okay? So absence of these, okay, Howell-Jolly bodies after splenectomy suggests that there is certain amount of, again, some splenic tissue in the form of something called as accessory spleens, which are also called as splenunculi. So if the Howell-Jolly bodies should be present after splenectomy, if they are absent, it means that you have not completely removed the splenic tissue. There is some amount of splenic tissue somewhere else which you have missed out, and you have to remove them for the proper result. Okay. There are certain structures called accessory spleens. These are as good as normal spleen. They are actually a miniature structures. So they contain capsule. They perform all the splenic functions. Okay. These accessory spleens are mostly associated with certain hematological disorders. So it is your duty as a surgeon to search for these accessory spleens and remove them also, okay? Or else the function will be totally lost, okay? 80% of the time, these are located at the hilum and they are usually having a pedicle. So like same like spleen, they have their own vascular supply, that is arterial supply, as well as a venous drainage, okay? The most common sites are, one is the hilum, next at the gastrocolic ligament, tail of the pancreas, greater omentum and the greater curvature. So please remember this order. The most common site is hilum, okay? Next is gastrocolic, tail, greater omentum and the greater curvature of the stomach. What are its functions? One is secretion of IgM, okay, in the acute inflammatory reaction, opsonins, and immunological reactions. They actively help in the phagocytosis, okay. Any foreign bodies or bacteria or so all this, any parasites, they help in the active phagocytosis, okay. And also the destruction of senile or abnormal cells, okay, predominantly RBCs or even the platelets, okay. And also phagocytosis of the foreign substances, not only the organisms, even the foreign bodies can also be actively phagocytosed by the spleen, okay. They act as a platelet reservoir as well as blood reservoir. So in case of shock or any cytopenias, the cells will be immediately replenished into the circulation through the splenic vascular supply, okay. And in the fetal life, its important function is erythrocyte production, okay. They also produce RBCs in the fetal life, and they also help in iron reutilization. As the RBCs are getting destroyed in the spleen, the senile RBCs, okay, that released iron will be helped in the reutilization for the new formation of the new young RBCs, okay. So it helps in the iron reutilization. Now, can you answer me? Splenosis means? Splenunculi means accessory spleen. What is splenosis? Any guess? Doctors, are you with me? Any guess?
Option C.
Okay.
C, ma'am.
So
C,
whenever
ma'am.
for any reason spleen gets ruptured, the ruptured bits, if at all they have any vascular supply, immediately they'll derive the blood supply from the, usually from the great omentum, and they start functioning as the unique spleen, okay. So rupture of the spleen and distribution of these tissue bits over the peritoneum is called splenosis. So during your splenectomy, you are not only search for the splenunculi, but also for this splenosis. So any tissue resembling the spleen should be removed. Coming to the splenic injury, I'll quickly go through this, okay. As I already told you, most common solid organ to be injured in abdominal trauma. The second common solid organ to be injured is liver. But as and large,
Liver.
the most common is spleen. Next is liver, okay. So it can get damaged or it can get injured in many forms, either by the blunt trauma or penetrating trauma, rollover by a vehicle, or fall on the ground, or fall of any heavy object on the abdomen, okay. So or it can be injured by penetrating injuries like any knife injuries or any sharp object or any bullet injury. So it can get injured by many ways, okay. But most commonly it is associated with, if at all there is blunt trauma, it is usually associated with lower rib fractures. If at all there are any lower rib fractures, rule out splenic injury. If at all there is splenic injury, always rule out thoracic trauma. So it is in a interchange manner. Never miss this rule, okay. So whenever there is lower rib fracture on the left side, immediately search for, look for, rule out splenic injury. Please take home. So if you forget the entire class, I don't mind, but please don't forget this very important thing in the practical point of view, okay. And it is more common in enlarged spleen. So a normal sized spleen, first of all, it is more prone for trauma. If at all it is enlarged, it is more prone for trauma and injury. So as a country, we harbor malaria in a very proud manner. So malaria, infectious mononucleosis, there are so many diseases which can cause splenomegaly in India. So it is common in enlarged spleen. So even a small trivial trauma, there need not be any high trauma, there could be a trivial trauma can cause splenic injury, especially in case of enlarged spleen, okay. Next, suppose if spleen is enlarged, so these are also prone for injury. One is tail of the pancreas, left kidney, splenic flexure, left hemidiaphragm, lung injuries, small bowel injuries. So all these could be coexistent. So suppose there is splenic injury, always rule out these injuries. So if you are exploring the abdomen, please make sure that these structures You have to look at all this structure. So what are the different types of injury that can happen? One is hematoma formation. Okay, the blood can get clotted and it can cause hematoma, or there could be a laceration, or it could be like a clean incised wound, or the pedicle. Once the pedicle is injured, this is called hilar injury, causing immediate devascularization and torrential bleeding. So it could be a simple hematoma, laceration, incised wound like thing, or any hilar injury. Okay. So these are the different pictures. So this is a hematoma, subcapsular hematoma, or there could be a laceration. So this is like a clean incised wound. So this is laceration. So this is damaged lower pole as well as the vascular pedicle. So this is complete transection. Transection means through and through the pedicle is cut, associated with the shattered spleen. That means the spleen has become into multiple pieces. So the last one is called shattered spleen. So there is grading system which is based on the CT scan. So it can be very easily remembered by this rule: 1, 1 to 3, 3 to 10, more than 10. And grade 5 is very easy to remember. So 1, 1 to 3, 3 to 10, more than 10. Okay. Lacerations less than 1 centimeter deep, and subcapsular hematoma less than 1 centimeter in diameter. Why should we grade any injury? Can you just guess why should we grade some injury? Why are we grading this?
For prognosis and treatment.
Exactly. So for the
Prognosis.
treatment, whether you should use your knife or you can manage the patient conservatively, when to be careful and when to take the patient for surgery. So this is the main concern both for the patient as well as the physician. So you should decide what to do with this patient, and also for the prognosis and the line of management. Okay. So for this purpose, up to grade 3, see, up to grade 3, you can manage conservatively, provided the patient is hemodynamically stable. Okay. Suppose a young person or a child comes who is hemodynamically stable. There is around 7 to 8 centimeter deep subcapsular hematoma. Okay. So in this patient, you can still try the conservative management. Okay. Once there is the hematoma is more than 10 centimeters, or if the laceration is more than 10 centimeters, or if the pedicle is lost, then definitely you have to, the patient will be almost 99 to 100%. The patient will be hemodynamically unstable, and you have to take up the patient immediately for exploration and then do the relevant procedure, usually either splenography or even splenectomy. Okay. So which surgery to do will be coming shortly. Okay. So the presentation, it depends on the nature and extent of the injury. Usually the patient presents with pain abdomen, shock if the blood loss is very severe, or if the extent of injury is very severe, the patient will directly present in the shock stage. Okay. Or pain in the left lower chest. So there won't be any pain abdomen. The patient might complain of only chest pain, dyspnea, that's it. Okay. So you have to rule out splenic injury. There could be any bruise or injury in the left hypochondrium, abdominal distension because of the hemoperitoneum, or any other associated bowel injury. The patient will be pale. Okay. Surgical emphysema. So this, remember this. Okay. That is escape of air in the subcutaneous plane. So this indicates that definitely you need ICD insertion, intercostal drain insertion, as well as the abdomen needs to be thoroughly evaluated. Okay. And features of other organ injury. If the small bowel or large bowel is damaged, there could be pneumoperitoneum, or there could be fecal peritonitis, or any abdominal distension, free fluid in the abdomen, or there is any crush injury of the viscera, or associated injuries can be present. So the patient might not isolatedly come with the splenic injury. So all these things can be there in a patient. Okay. Specific signs. Coming to the specific signs. Non-shifting dullness. If you remember medicine clinics, if you perform shifting dullness, you have to repeat the procedure on the opposite side also. Suppose there is shifting dullness on the one side and it is absent in the involved side, that is on the left side, it means that there is blood in the peritoneal cavity, but blood in the left side, on the left side of the abdomen, it is clotted. So you are not able to elicit shifting dullness on the left side, but it is there on the right side. So this particular sign is called balance sign. Okay, please remember this sign. It is very, very important. So in medicine, you will always be asked to repeat the shifting dullness on both sides. Okay, you are asked to do it on the both sides. But here what happens, it is present on the right side, it is absent on the left side because blood is there in the peritoneal cavity, but it is in the clotted form in the left side. So this is called balance sign. And there is Kehr sign, Kehr, Kehr sign. It is pain in the left shoulder. Okay, it's pain in the left shoulder due to irritation of the diaphragm because of the collection of blood under it. Okay, so this is called Kehr sign and latent period of band-aid. So what exactly is it? So it is delayed complication. A patient has come who is absolutely hemodynamically stable and you have diagnosed some 3 centimeter hematoma. Okay, you have admitted the patient for 24 hours observation. You have discharged him. Suddenly, within few hours, the patient comes to you in a stage of shock. Why? Because of the rapidly expanding subcapsular hematoma. So once you have sent home, the patient has, since I am discharged from the hospital, I can jump around. So like that, suppose the patient is very athletic, then suddenly the hematoma might enlarge, causing torrential bleeding. Okay, so this is called latent period of band-aid. That's why you have to observe the spleen patient, any injured spleen patient at least for 5 days in the hospital. Okay. So the famous signs, can anyone name what is picture A? What is picture A? Bluish discoloration around the umbilicus. What is it? Suggestive of hemoperitoneum. What is this called? Umbilicus Cullen sign. Okay, Cullen. So Cullen umbilicus. So can you see the rhyming? Cullen umbilical. Okay, it is bluish discoloration around the umbilicus, Cullen sign, and this is called Gray Turner sign. Yes. Left-sided flank bluish discoloration is called Gray Turner sign, suggestive of hemoperitoneum. So these are also pathognomonic features. Okay, one is balance sign, Kehr sign, Cullen sign. Next it is Gray Turner sign. Okay. So this is the root. So this is why the referred pain in the tip of the left shoulder through the phrenic nerve, that is C345. Any blood under the left hemidiaphragm, the pain will be referred to the left shoulder. In the same way, in case of post-laparoscopy, the patient will have right shoulder pain. Usually, it is because of the irritation of the dome of the hemidiaphragm through the mediated through the phrenic nerve. Okay, so this is the Kehr sign. So blood under the left hemidiaphragm causing left shoulder pain. I think I am clear up to this point.
Ma'am, can you repeat what is Gray Turner sign?
It is the bruising of the bluish discoloration of the left flank.
Okay, ma'am.
Flank. Okay, left flank. This is bluish discoloration around the umbilicus is called Cullen sign.
Cullen sign.
Okay. Shall I proceed or shall I repeat?
No, ma'am, you can proceed.
Thank you. Okay, what are the investigations? Immediately, the patient has to be admitted and strictly immobilized. He should not be made to walk around. Okay, and then hemodynamically, the ABCs have to be followed. Okay, and stabilization of the patient. Don't be in a hurry to send for investigations first. You have to hematologically stabilize the patient, send for ABC, blood for grouping typing, and thorough clinical assessment has to be done. And if necessary, if you suspect any pleural injury, any collection in the pleural cavity, don't hesitate to put intercostal drain and then strict input-output chart, nasogastric tube, because there will be gastric dilatation in these cases. And in order to decompress the proximal bowel, you have to insert the NG tube and keep the patient nil by mouth. Okay, and blood for cross-matching has to be sent, and all other relevant hematological investigations, including blood for cross-matching, everything should be kept ready. So at any time, you should be ready for laparotomy. Okay, you have to immediately take up the patient In case of any hemodynamically unstable, the patient is in a refractory shock in spite of pumping so much of fluids, okay, crystalloids as well as colloids, the patient is not getting stabilized, then you have to suspect the pedicle injury or very severe injury, and you have to immediately rush the patient for the laparotomy and procedure. Okay, so keep all the investigations ready. Though the patient is hemodynamically stable, you have to treat as if the patient might necessitate surgery at any time. So you have to be ready for a war. Okay, so in case of stable patient, okay, suppose the patient is stable, you can do your investigations. One is diagnostic peritoneal lavage, okay, or CECT abdomen, okay, contrast CT abdomen, which will also tell the extent of the injury and the vascularity, any other associated injuries. Suppose you don't have CT facility, you can go ahead with the fast ultrasound. So all the quadrants you can assess and immediately you can arrive at certain diagnosis, okay, and then chest X-ray to rule out the rib fractures or any pleural collection. So it could be pneumothorax or hemothorax or hemopneumothorax with or without rib fractures, and then erect X-ray abdomen if the patient is in stable condition. That's why I'm telling stable patient. You cannot subject a 80 systolic patient to a erect X-ray abdomen. You should not do that. Okay. Next is splenic Doppler. If you have facility, go ahead with the splenic Doppler if the to see if there is any discontinuity in the vascularity of the spleen. Okay. Next, suppose if you are planning for splenectomy, if it is emergency splenectomy, the incision should be liberal, usually midline. Okay, look for the other organ injuries and first secure the pedicles. So all your clamps have to be fast. Okay, all the clamps you have to put very, very fast. You have to deliver out the spleen. So your decision whether to go for complete splenectomy or partial splenectomy. Okay, if the lower pole, usually the lower pole will be retained. So if at all you are planning for the partial splenectomy, so there will be a lower pole small pedicle, you can retain that. If the spleen is not that much damaged, if the vascularity is preserved, you can go ahead with something called as splenorrhaphy. Like our herniorrhaphy, here you are not removing it, you are going to ensheath. That means you are going to wrap a mesh around the spleen and you are going to secure it, okay, so that the spleen can be conserved. Okay. Next, or you can go ahead with the gel foam application, suturing, reverse suturing. So with a blunt reverse end of the needle, you can even suture the spleen by keeping the omentum as a cushion, or if at all there are any multiple small bits, okay, any devascularized or devitalized tissue in the spleen, if the vascularity of the other parts of the spleen is well preserved, and if you are able to achieve hemostasis, you can just do the debridement, remove the devascularized or devitalized tissue, and you can come out. Okay. So these are the spleen conserving measures. That is partial splenectomy or splenorrhaphy. Okay. Whereas if you have to remove the spleen, in case of a shattered spleen, you have to go ahead with the complete splenectomy. So this is a picture of mesh splenectomy. So this mesh is placed, it's ensheathed. So the spleen is completely wrapped, except at the pedicle, it is completely wrapped around with the mesh, so that you are trying to preserve the spleen. Okay. Or if the vascularity is slightly preserved and the spleen is almost, it is vital, but it is injured very lightly. Okay. So such spleen can be auto transplanted. So if it cannot stay in the left hypochondrium, you can keep it in the greater omentum. Okay, it will immediately derive its vascular supply from the greater omentum. You already know greater omentum has a very, it is a very kind-hearted organ. So it will immediately give its vascular supply to any organ or any structure to which it is going to get attached. So you can auto transplant the spleen into the greater omentum. So these are few spleen conserving surgeries. So one is splenorrhaphy, that is mesh splenorrhaphy, or auto transplantation of the viable spleen into the greater omentum. Okay. So this is splenectomy. So you have to insinuate your hand. You have to deliver out the spleen as shown in the second picture. You have to deliver out and put your clamps immediately. Okay. Suppose the spleen is bleeding very much, you have to insinuate your finger under the hand, under the rib cage. You have to pull out the spleen and immediately clamp the pedicles. Okay, this step should be very, very fast. Okay, then only you can achieve rapid hemostasis, or else the blood loss will be very, very fast. Okay, the patient will collapse very fast. So you have to deliver out the spleen and then you have to put your clamp. This is very, very important. The entire splenectomy thing will depend on this slide. Okay, when do you go for non-operative management? That means when you need not operate. Okay, one is there are no associated injuries, so it is a luckily isolated splenic injury, and close monitoring facilities available. So there should be any ICU facility with immediate ABG, good nursing care and a specialist care, and the facility of operation has to be there. And then grade 1, 2, 3 can be managed in a hemodynamically stable patient in a conservative manner, that is non-operative manner. And suppose if it is a non-expanding hematoma or non-progressive injury, suppose you do CT scan today, the patient is hemodynamically stable, and day after tomorrow, if you repeat the CT scan, the size of the injury, the size of the hematoma is same, then also you can go ahead with the non-operative management. And in case of children, try to preserve spleen, because there will be overwhelming the OPSI, which we will be dealing shortly. So that OPSI will be very fatal in children. So try to conserve spleen in children. And if there is no fall in the hematocrit also, then also you can go for non-operative management. So a 27-year-old patient with road traffic accident, hemodynamically stable, CECT shows grade 3 splenic injury. The treatment of choices. This was asked many times, almost in option C. Exactly. So it is conservative management under careful monitoring. Because
Conservative.
okay, excellent. Because he's a young patient with a road traffic accident. And ideally, there should be no other organ injury should have been mentioned, but he has not mentioned. But it's okay, hemodynamically stable, and CECT shows up to grade 3 injury. Okay, so less than 10 centimeters hematoma or laceration. So the treatment of choice need not be splenectomy. TRAPI is also not advised. The patient can be safely under careful monitoring. The patient can be managed conservatively. Why not splenic artery embolization? Why can't you think of this? Or isn't it pulling slightly? Okay. Because it is a non-progressive injury. Okay. Hemodynamically stable. So this word, so this sentence, so it usually goes in favor of conservative management. Suppose the patient is suppose if they add some other statement like the patient has recently deteriorated. So in that condition, you can take the option as either splenic artery embolization or even splenectomy. You can go ahead. Okay. So in a young subject with grade 3 injury, hemodynamically stable, you can go for conservative management. What are the other indications other than trauma? So trauma, because we are in India. So, but there are certain other indications for which the person from medicine department, they will be sent to you. Okay. So one is ITP, idiopathic thrombocytopenic purpura, trauma, hereditary spherocytosis. This is also very important condition. Please remember this. Splenic tumors, hypersplenism. May I know what is hypersplenism?
Over-functioning spleen, ma'am. It's destroying normal RBCs also.
Okay. Now, is it only RBCs?
No, all cells.
Yes.
That means
So it is.
All the
So the spleen is not only enlarged, but also it is over-functioning, causing penia, pancytopenia. So all platelets, RBCs, WBCs, everything, the counts are low. This is called hypersplenism. And also in case of splenic tumors and also splenic abscess, if there are multiple abscesses, you can go ahead with the splenectomy. If there is any, for some reason, there is splenic infarction, either because of trauma or atraumatic causes, splenic vein thrombosis or splenic artery thrombosis causing infarction of the spleen, or as a part of certain malignancy surgeries like pancreatic malignancy. Suppose if you are doing any pancreatic malignancy surgeries, you as a part of the procedure, you are even going to remove the spleen also. And also you can do splenectomy in autoimmune hemolytic anemia, tropical splenomegaly. If there is massive splenomegaly, you have to go ahead with the splenectomy. In case of CML, okay, thalassemia. So these are the least common indications for splenectomy, okay, and Hodgkin's lymphoma also. So the splenectomy can be performed, and also as a part of pancreatic malignancy surgeries, you are going to remove the spleen also. What are the complications? The most important complication, the most common complication is left basal atelectasis. Suppose you have done, so this is the most common. So if you have operated today morning, in the evening, definitely the air entry will be decreased on the left side, and there is atelectasis. The patient will complain of chest pain. On the second or third post-operative day, the patient might have pneumonia also. So you have to be very, very careful. Okay, you have to encourage the patient to have active breathing exercises. Okay, as a consultant, please look for this because the incidence is 80 to 90%. So this is the most expected complication. The other complications are hemorrhage, usually from the short gastric vessels, slipping of ligatures, okay, because you might be doing in a hurry, and the short gastric vessel pedicle is the most common one to give away, okay, and acute gastric dilatation. So this is the third most common complication. For some unknown reason, okay, the stomach suddenly gets dilated, and even it can extend up to the lower abdomen also. So the acute severe gastric dilatation, it is sudden massive dilatation. So usually you would have kept the NG tube. Suppose if it is not there, immediately insert the NG tube, and usually you find hypokalemia. So the potassium levels will be very low, and the patient will be usually in hypotension. So fluid and electrolyte imbalance has to be immediately or slowly, it has to be corrected. The patient should be on nil by mouth, and also NG tube has to be inserted. Okay. Then hematemesis. This is also one of the complications you'll be seeing in your post-op ward. Okay, because of the ligation of the short gastric vessels, because of the back pressure, the gastric mucosa, the small capillaries of the gastric mucosa will burst and causing hematemesis. Okay, this is also important complication. Left subphrenic abscess. Okay, injury to the tail of pancreas. It's very common during putting pedicle ligation. Okay, and deep vein thrombosis, as it is post-op complication of almost every surgery, but it is very specific to the splenic surgery because of the chemo concentration. Okay, and also the most dreaded complication, overwhelming post-splenectomy infections. Overwhelming post-splenectomy infection. Okay, what is OPSI? Okay, it is, they are more prone, especially with the capsulated organisms, not only bacteria but also the even parasites. Okay, most common is pneumococci in the order, in the descending order, H. influenzae, Neisseria meningitidis, Babesia, and other capsulated organisms. It is more pronounced in immunocompromised individuals, either in HIV, or if the patient is a uncontrolled diabetes mellitus, or even if the patient is on anti-cancer drugs, it is more common. The incidence is 4 to 6%. So these are the typical catchy MCQ percentages, okay? And reduced IgM, because the spleen produces IgM and there is properdin. So this causes defective phagocytosis and quick sepsis. The sepsis will progress very, very swiftly, okay? Most common in first 2 years of surgery. So after splenectomy, the patient, you have to keep strict vigilance on the patient. You have to reinforce the patient to come for regular follow-up. Okay, at least for 2 years, please come. So you have to scare the patient, literally threaten the patient, not just undergo surgery and vanish. Okay, what are the clinical features? One is fever with chills and rigors, odynophagia, okay, usually pneumococcal infection, and dyspnea because of the pneumonias, then hypotension, multi-organ failure. The rapid progress of sepsis is the pathognomonic feature. So within minutes to hours, the patient will rapidly deteriorate, leading to multi-organ failure. So there could be pneumonia, ARDS, okay, renal failure, hepatic failure, and death. Okay, so it is very, very dreadful condition. You have to first prevent it, treat it aggressively, and also you have to take certain precautions. Okay, so one is, if you are planning the patient for elective splenectomy, if you have time, okay, for hematological disorders, you have to give pneumococcal and Hib vaccine, H. influenza B vaccine, 2 to 3 weeks prior to the surgery. Okay. And then children older than 2 years, they also have to be immunized. Okay. And if it is done in an emergency basis, within 20 days of surgery, the patient has to receive these 2 vaccines, at least the pneumococcal and Hib vaccine. Okay. And anti-malarial prophylaxis has to be given in the endemic areas. And the booster doses of these vaccines have to be given every 5 years. Or some people will assess the immunoglobulin values in the blood, and then accordingly you can give the booster doses. You can plan the booster doses. This is the most common strain of vaccine you give. Okay, it is different for children. This is the most common splenectomy, this prophylaxis. This is the strain of the vaccine. Okay, it is usually avoided in pregnancy, and lifelong prophylaxis with benzathine penicillin has to be given. Certain centers, institutes, they usually do not recommend, but most of the centers will recommend benzathine penicillin, lifelong prophylaxis, or at least even for 5 years. Okay. Then the treatment of OPSI is the patient has to be admitted in ICU, and these are the antibiotics. If the patient is developing ARDS, he has to be under the ventilatory care and immunoglobulin transfusion. Okay. Management of sepsis and multi-organ dysfunction. So the depends on the renal failure or hepatic failure, or if the patient is in DIC, the patient has to be treated accordingly. Okay. The most common complication of splenectomy is very easy.
D, option D.
Lower lobe
atelectasis. Okay. Almost in 75 to 80% of the post-splenectomy cases. True about the splenunculi. Let's go fast. Okay. True. Any guess?
Most common site is tail of pancreas.
Actually, I told you the splenunculi, they almost anatomically and functionally resemble the spleen. So they are encapsulated. They are multiple. The most common site is hilum. Okay. The most common site is hilum. The next common site is tail of the pancreas. So they have more red pulp than spleen. No, it is not like that. So they contain equal amount of red pulp as well as white pulp. So the most relevant option would be encapsulated, because the most common site is not tail of the pancreas, it is the hilum. They are usually multiple.
Hilum.
So the red pulp, white pulp doesn't matter. So almost they contain equal amount. Okay. Usually multiple, and next most common is tail of the pancreas and more prone for torsion. Okay, this one.
Streptococcus.
Yes, Streptococcus pneumoniae. The next common is H. influenzae. Okay, the least is Mycobacterium.
Babesia.
Babesia is also capsulated organism. If you say the last option would
Yes,
be Mycobacterium. Okay.
Mycobacterium.
Okay. The vaccine for post-splenectomy is given for all except it is
E. coli. E.
Escherichia
coli.
coli.
Escherichia coli. Okay, Escherichia coli. Coming to the hematological disorders, so usually they'll be dealing in medicine, but how relevant is it in surgical patients? I'll quickly go through. I'll very quickly go through. It is development of IgG antiplatelet antibodies leading to thrombocytopenia. So the spleen is the common source of these antibodies. So why we are removing the spleen? It is because of this reason, because the spleen is producing these antibodies and causing thrombocytopenia. So it is destruction of the platelets. So what happens when platelets are getting destroyed? The bone marrow will not sit quiet. Okay. So it will produce more and more megakaryocytes. Okay. And it is more common in females below 40 years of age. Please remember these figures. And most of the cases, almost in 80% of the cases, there is spontaneous remission. So it is a very transient episode of thrombocytopenia. Okay. It is because of the auto destruction of the platelets because of the IgG antibodies produced by the spleen. So the investigations we do are thrombocytopenia. You will see the decreased platelet count. Other cell counts are normal. So the RBCs, WBCs are normal. It's not pancytopenia. Okay, rule out other causes of thrombocytopenia. So you have to rule out multiple causes of thrombocytopenia. Most common is any viral hemorrhagic fever. So first you have to rule out them, and then malignancies, and then you have to come at this diagnosis as an exclusion. Okay, so it is mainly the diagnosis of exclusion. You have to rule out other conditions, and the last diagnosis would be okay. Now all these are ruled out. Now the diagnosis is ITP. So in this way, by the exclusion, you are arriving at this diagnosis. So when do you do splenectomy? So this is the surgical relevance. Okay. So suppose there is relapse. So what is the treatment of choice for ITP is, it is corticosteroids. Okay. How long you have to give? So you have to give maximum for up to 6 weeks. Okay. Suppose even after giving for 6 weeks, there is relapse and the thrombocytopenia is very, very severe. It is less than 10,000. It is not at all responding. Then you have to go ahead with the splenectomy. And if the girl, if any girl child, if she attains menarche, so there will be definitely loss of blood, severe blood loss during menstruation. So in case of refractory cases with severe thrombocytopenia, if the girl is has attained menarche, please do splenectomy, or else there will be very severe menstrual blood loss. Okay. Suppose if the patient is on therapy, not only with the corticosteroids, but also on the immunosuppressants, the patient is refractory to medical management, more than 6 months, you have to do splenectomy. Suppose if the patient is in the second trimester of pregnancy, so second trimester is usually the safe period, and if the platelet count is less than 10,000, you have to go ahead with the splenectomy. Suppose there is recurrence, you are given corticosteroids or the immunosuppressants, everything, okay, but still there is recurrence, then please do splenectomy. Suppose there is profound GI bleed or intracranial bleed, definitely the spleen has to be knocked off. So the treatment of choice for ITP is of choice. So
Steroids.
Steroids, okay.
Ola-
Since we are
steroid.
dealing with spleen, we can answer. But suppose if it is given among 300 MCQs, you have to think very carefully. So the treatment of choice first is, it is corticosteroids always, okay. Then you have to take with the other, okay. The Kehr sign seen in splenic rupture is
Pain in left
Pain in
shoulder.
Pain in left
pain
shoulder.
in the left shoulder. Any collection of blood beneath the left hemidiaphragm through phrenic nerve, there will be referred pain to the left shoulder. This is called Kehr sign. Okay, coming to hereditary spherocytosis. So this is also one of the most common causes where the patient from medicine department will be sent to us. Okay, so what is it? It is an autosomal dominant condition. It affects males and females equally, whereas ITP, it affects females most commonly, whereas here there is equal incidence. What is the reason? What happens? So the RBCs, which are supposed to be biconcave, okay, we have biconcave shaped RBCs, okay, but here they have become spherical in shape. It is because of the increased sodium influx, and this increases the permeability of the membrane, leading to more influx of fluid, leading to the spherical RBC. What is there? Let the RBCs be spherical. What is the problem? What will be the problem?
Oxygen carrying capacity is
Yes. So the RBCs have to squeeze through tissues to supply oxygen. So if any change in the shape or contour of the membrane of RBCs, they cannot effectively deliver the oxygen to the target tissue. So such abnormal, any abnormal RBCs, maybe it could be spherocytes or elliptocytes or any abnormal RBCs, the spleen will not tolerate, okay? So it will immediately destroy the RBCs, leading to increased destruction of RBCs. So what is the basic pathology is, it is defect in the RBC membrane due to spectrin ankyrin band 342, 4 part 2 protein. So this is defective protein. So these cell membrane, these substances will be defective. Okay, so please try to remember. Okay, so these are the normal biconcave RBCs with the central pallor, whereas these are the spherical RBCs. They are smaller in size compared to the normal RBCs and there is no central pallor. What happens? Okay, suppose let the spherocytes be there. So it will cause hemolytic anemia, jaundice, okay, because of the increased bilirubin turnover, unconjugated hyperbilirubinemia, jaundice, cholangitis, and pigmented gallstones. So any child or a young adult with gallstones, always rule out the hematological disorders, especially hereditary spherocytosis or sickle cell also. Okay, so the patient will be pale. There is pain abdomen, hepatosplenomegaly, and they are more prone for infections. Okay, and there is something called as acute hemolytic crisis. It can be precipitated by any stress, okay, any mild stress, okay, psychological stress or physical stress or any infection, small infection, a small tooth abscess or any periodontitis. So small, any infections can lead to severe hemolytic crisis that will cause pain abdomen, fever, jaundice, and gallstones. So all these can lead to acute hemolytic crisis. So the investigations you do are, one is fragility tests, okay, in 0.6% solution, okay. The RBCs immediately will attain spherical shape, okay. Ultrasound abdomen, if you do, they will show splenomegaly and gallstones, okay. Any young subject with gallstones, you have to do complete evaluation, look for these organomegaly as well as the hematological this fragility test. Peripheral smear is most useful, okay, and raised parameters in liver function test, unconjugated hyperbilirubinemia, increased reticulocyte count because of the increased turnover of RBCs. The RBCs are getting formed, they are becoming into spherocytes, and they are actively getting destroyed in the spleen. So there is increased reticulocyte count, okay, and peripheral smear you have to do. So the management consists of blood transfusion and splenectomy. One of the most common indications is hereditary spherocytosis. And after splenectomy, the response is very, very tremendous, magical, okay. The patient will improve within days to weeks, okay. So the result is beautiful. So it's a surgery is, so you are completely justified by doing splenectomy in case of hereditary spherocytosis, okay. And again, the same thing, preoperatively pneumococcal and hip vaccine has to be given. And nowadays we are doing laparoscopic splenectomy. If there are gallstones, you have to do cholecystectomy also in the same sitting, okay. And the accessory spleens have to be searched and they have to be removed, or else again the story will come to square one. Again, those accessory spleens will get enlarged and they will start functioning as normal spleens, and again your history will repeat, okay. So accessory spleens have to be searched for and the complete removal has to be ensured, and the patient has to be on regular follow-up at least for 5 years. Coming to the sickle cell disease, okay, it is more common in blacks. The HbA, the adult hemoglobin, is replaced by HbS, leading to the sickling of RBCs. So there is increased blood viscosity, and these sickle cells, okay, they have tendency to block the vessels, small splenic vessels especially. So it will cause multiple splenic infarcts. So initially the spleen enlarges, and because of the infarction at multiple sites, the spleen starts shrinking, okay. So sometimes the splenectomy need not be done in these cases because of the clogging of the blood vessels and recurrent infarcts. Sometimes the spleen even gets something called as autosplenectomy. Because of the clogging of blood vessels, the spleen might even completely disappear, or it can be in a rudimentary form. This is called as autosplenectomy, which is pathognomonic of sickle cell disease. So in case of sickle cell disease, don't be in a hurry to do splenectomy. And the typical leg ulcers, which with itching around the margins. So any ulcer case, please don't take it very lightly, especially in case of a female. If she comes with multiple painful leg ulcers with itching and hyperpigmentation around the ulcer margin, and if there is any pain abdomen, if there is any gallstones, then you have to think of sickle cell disease, okay. So these are the normal RBCs, these are the sickle RBCs, okay. So these are the normal biconcave. So these are the sickle shaped RBCs, which will cause clogging of the blood vessels and then leading to multiple microinfarcts, okay. So the HbA will be replaced by HBS. A single amino
Yes.
acid where
Yes.
glutamic acid is replaced by valine. Your famous question asked in medicine. Okay. So at the glutamic acid is replaced by the valine. The clinical features are anemia, pain abdomen, jaundice, leg ulcers, typical leg ulcers, initially splenomegaly, and later because of the autosplenectomy or shrinking of the spleen might not even be found also. And other infarction, features of mesenteric infarction, cerebral infarcts also have been reported. And if you do HB electrophoresis, you can detect the HBS on hemoglobin electrophoresis. Okay. And on ultrasound, there could be gallstones. So this splenectomy is useful if the patient is in severe hemolytic crisis. Not if the spleen is rudimentary, you need not do splenectomy at all because it's not going to be very useful. We are coming almost near the end of the class. Splenectomy is most useful in
thalassemia.
Hereditary spherocytosis.
Okay, hereditary spherocytosis, it is very useful
Absolute
because
indication.
it will give dramatic response. Okay, dramatic response. There will be massive splenomegaly and the patient will be in severe hemolytic crisis. So it is most useful in cases of hereditary spherocytosis. The second most useful would be autoimmune hemolytic anemia. It is least useful in sickle cell disease. If at all, if it is useful, it has to be done in acute hemolytic stage, not after the autosplenectomy. Thalassemia, it is last, almost in
Last option.
intractable cases, you have to go ahead with splenectomy in thalassemia. So in the order, it is C, D, A, and B. So it is most useful in hereditary spherocytosis. It has been asked many times. And also, why not autoimmune hemolytic anemia? Because conservative management is still treatment of choice. You have medicines to treat, whereas hereditary spherocytosis, the medical management is the response to medical management is very poor. Coming quickly to splenic abscess, the most common causes are infective endocarditis. So this is the most common cause of a splenic abscess in case of immunosuppressed individuals, polycythemia, sickle cell disease, and then tuberculosis, trauma. Suppose there is a hematoma which has got secondarily infected, or any septic focus, be it adenoiditis or tonsillitis, tooth abscess, or any small sepsis can throw any septic embolus causing splenic abscess. Okay, the common organisms are staph, strep, Enterobacter, Escherichia, Klebsiella, Mycobacterium, and Candida species. The specific feature is tender splenomegaly, fever, pain abdomen, left basal pneumonia. Usually it is associated with pneumonia. Okay, the abscesses can be single or multiple. So in this case, so you are seeing a CT scan from the foot end of the patient. So it is the left side. This is the right side. So on the left side, you are seeing the large splenic abscess. Okay. So in this case, this is the spleen. It is enlarged and there are multiple abscesses in this case. What to do? First is broad spectrum antibiotics have to be given. Suppose if the abscess is large and slightly peripherally located, you can do USG or CT guided aspiration. Because you don't have multiple pockets, you can easily go ahead with the USG or CT guided aspiration. Splenectomy is indicated in cases of multiple abscesses. So you cannot keep on aspirating, it will cause a lot of hematoma and there is high chance of recurrence. So in such cases, multiple abscesses, you can go ahead with splenectomy. Suppose if there is rupture of the abscess, then you have to go ahead with the laparotomy and then decide on table whether to go ahead with splenectomy. Usually we do splenectomy in cases of ruptured abscess. There is some entity called atraumatic rupture of spleen. So the rupture of normal sized or enlarged spleen, it is usually seen in unduly mobile spleen. Okay. Why it occurs? Because of the sudden constriction of the splenic vessels or there could be occult rupture due to microtrauma. The patient might have forcefully turned, even the rollover on the bed can cause trauma to the spleen and lead to rupture of the spleen or splenectomy. Okay, there is some criteria called Orloff and Perkin criteria. So this was asked in PGI exam. Okay, this is the Orloff-Perkin criteria. Just remember the name. There is another condition called splenic artery aneurysm. Okay, it is the second most common intra-abdominal aneurysm. What is the most common intra-abdominal aneurysm? It is aneurysm. Anagane manak. What do you remember? It is the aorta. Okay. After that, after aortic aneurysm, it is the second most intra-abdominal aneurysm common is splenic artery aneurysm. It is common in women. Okay. And it is mostly associated with atherosclerosis. Okay. There is something called as pseudoaneurysm. What is the difference between true aneurysm and pseudoaneurysm? In pseudoaneurysm, only few layers of the blood vessel wall are involved. It is usually seen after acute severe pancreatitis. It can even rupture the splenic artery, okay, leading to fatal hemorrhage. Okay, so the vessel can even get ruptured. And splenic vessel calcification can be seen, and it is one of the differential diagnoses of unexplained hemoperitoneume. So there is in a patient, we have seen 3 such cases in my life. I'm very fortunate to see this. Okay, there is hemoperitoneume, spleen is normal, mesentery, there is no mesenteric bleed, there is no omental bleed, nothing is there, liver is normal, literally are unable to trace, the hematological parameters are normal, there is just unexplained hemoperitoneume. When we explored properly, there was splenic artery aneurysmal rupture. Okay, immediately went ahead with the splenectomy. So if you see the longitudinal CT, so this is the tortuous and dilated aneurysm of the splenic artery. Can you make out? So this is the wedge-shaped spleen. So at the hilum, along the long axis of the hilum, the splenic artery is enlarged. Here in this case, you can either go ahead with splenectomy or even the splenic artery embolization can also help in these cases. Okay, usually we do splenectomy. When do we do surgery? If the diameter is more than 2 centimeters and if it is identified during pregnancy and it has to be operated in second trimester. You don't want to take chance. Okay, it can cause any torrential hemorrhage at any stage. Okay, splenectomy with ligation of the pedicle proximal to the aneurysm. Suppose if the aneurysm is near the hilum, you have to go behind and you have to proximally ligate the aneurysm. Or you can even try the splenic artery embolization. Are there any doubts, doctors? So at the end of this class, I want you to remember what are the spleen conservative surgeries and in which conditions you are going to retain the spleen and in which conditions you are going to remove the spleen, the preoperative prophylaxis, the intraoperative complications and the immediate post-op complications, the most common one, and what are the certain hematological disorders requiring splenectomy and in which condition it is very useful and in which stage of autoimmune hemolytic anemia it is useful, in which stage of sickle cell disease it is useful and it is not useful, and presence of gallstones in a young subject, rule out these hematological disorders, remove the spleen as well as gallbladder you can remove in the same sitting. So if you understand these concepts, I think my job is done with this class. If you have any queries, please get back to me now. Any doubts, doctors?
Ma'am, after splenectomy, ma'am, Howell Jolly bodies can persist?
Yes, they have to be seen. Okay, Howell Jolly bodies have to be seen after splenectomy. Okay, so what exactly are they? They are mainly the nuclei. Okay, suppose if the Howell Jolly bodies are not seen after splenectomy, it means that there is some spleen-like tissue somewhere else which you have missed out. So it is an incomplete procedure for the patient. So whenever the complete spleen tissue, the splenunculi, everything, if it is removed, Howell-Jolly bodies is an excellent indicator that you have done complete removal of spleen or spleen-like tissue. So the absence of Howell-Jolly bodies indicate that there is some spleen tissue somewhere else which you have missed out. So again, you have to re-explore.
Okay.
Okay. Many people, many students ask this question. Even I used to wonder, okay, why they are asking. So it is very important. So the spleen function is, just try to remember, if there is spleen, there is no Howell-Jolly bodies. If the spleen is removed, Howell-Jolly bodies are not seen. It means that there is some splenic tissue remaining inside the body, or some tissue which is resembling in function the spleen. It is not, it is a very incomplete removal, and you have to again go and re-explore. Yes, any further doubts? Any doubts, doctor?
No, ma'am.
No, ma'am.
Okay, thank you. Shall we sign off? Thank you. Wish you all the best.
Thank
Please
you, ma'am.
read immediately. Thank you, ma'am. Thank you. Thank
Jyoti, it was a very good class, Jyoti.
Thank you. Thank you, Dr. Ramya.
So,
I hope our people have understood the main concepts, the surgical aspects of the spleen.
Ma'am, what if question is asked, what is the most common cause of spontaneous rupture of the spleen? That is malaria or any other?
Usually in Indian scenario, it is malaria because the spleen will be in enlarged state. Most of the time, many of the Indian population, with or without symptoms of malaria, we will be harboring the parasites, and most of the cases there will be splenomegaly. In my clinical experience, there was a patient referred from medicine department, a case of malaria, which is about to get discharged. He is immediately sent to the surgery department because of the suspicious rupture of spleen. Okay. So what he has done is, he has malaria, he has taken the anti-malarial treatment, and then he was about to get discharged. He has slightly rolled on the bed, a bit suddenly he has rolled on the bed. So this has called minor twisting of the spleen, or even the pedicle, or I don't know what would have got twisted. So the enlarged spleen is more prone for even a trivial trauma. So the most common cause of spontaneous rupture of spleen, especially in Indian scenario, is usually malaria. And if you go towards the northern India, then it is Kala Azar, then infectious mononucleosis. So all those causes will come in the next place.
Okay, ma'am.
Okay.
okay, Jyoti.
Okay.
Thank
Okay.
you. Very
Thank you
nice
very
class.
much. Thank you.
Okay,
Thank
we'll
you.
meet in the next session.
Thank you so much all.
You can get back to me by app also. Thank you. Thank you very much, sir. Thank you.
Thank you so much. Thank you, madam.
Thank you. Thank you.